5, 6. Sherry, while he's getting them live stream, do you care if your transcript is in the 4 boxes or a full transcript?
Full transcript.
Okay, great.
Thank you.
This conference will now be recorded.
Okay, we are now live streaming. You can feel free to begin the meeting.
Thank you. Good morning, everybody. Welcome to the ICD-10 committee, June 9th, 2021. We'll begin today's meeting by going over the minutes. The last time we met was in April, so this is to approve the April minutes. I know those were circulated, so if there's a motion to approve in a second. Motion. Dr. Reddy moved and Dr. Johnson seconded. All in favor say aye.
Aye.
Aye. Yep, thank you. Any opposed? Okay, hearing none, that carries. And we'll move on to the first item on the agenda, which is the tool and website improvement update.
Thank you. So just to provide you all with an update from our last meeting 2 months ago, we had sent out a survey as well as a link to a test page for all the board members to review. We also reached out to various associations for other prescribers to give us some feedback on things that they thought they would find helpful on the website, as well as any feedback they have on the tool and utilizing it, the ease of utilizing it, what they feel they could get most out of it. And so we did get some responses. We went ahead and did some updates, a little bit of cleanup on a couple links that were no longer working, as well as making some additions to some other useful resources. And one of the big things that we are looking at with the pharmacy board was something Dr. Schottenstein had brought up in a previous meeting, as well as in his response to me about the mental health conditions that were listed in the tool as conditions for opiate prescriptions, and why they were there, if they needed to be there, and kind of taking a look at that to see how useful that would be. So in meeting with the pharmacy board to talk about their data integrity project, we brought that up to them and we asked them to kind of think about that. And as they looked at their data and they continue their project to review the data, to see if that would be something that we should continue to maintain on there. And so we'll report that back out once we do get more information back from the pharmacy board.
Thank you.
You're welcome. That was the big update, at least for our half of things. I can go ahead and provide the pharmacy board update, or if anybody has any questions before I move into that.
Are there any questions? Okay, I would like to ask a question. So, this whole project in regarding the improvement of the tool and improvement of the website, could you tell me sort of the timeline of when you see this, I guess, being rolled out and active and, finalized?
Sure. We were actually hoping to have it done and ready now for this meeting. However, the pharmacy board is still continuing their data integrity process. So we really want to make sure that data is accurate before we do an official release. I had a meeting with the pharmacy board at the end of May to talk about that process and to see how things were moving along. And they had a meeting with their vendor, and they wanted to work out some internal issues with their vendor first before they started reaching out for more feedback relating to the reporting of those ICD-10 codes. Part of their integrity process was identifying if there were some errors that were leading to maybe secondary diagnosis being identified, like Dr. Schottenstein had pointed out. Maybe the primary diagnosis for receiving the opiate prescription was a fracture. However, the patient had also been treated for a depression. And so the EMR may have been pulling the wrong ICD code. So the pharmacy board is working on that, and we want to make sure that we give them enough time to work on that, so that way we have the most effective tool possible.
Yeah, thank you.
I'm hoping it'll be fairly soon. They really have been working really hard on it. So I don't have a specific timeline, but we were really hoping like in the next month to get it rolling.
Yeah, and operationally, as someone who does this every day, and most EMRs are now integrated for the electronic prescriptions to pull that primary diagnosis onto the script, because this isn't unique to Ohio. It's sort of happening all over in terms of reporting codes. But that is a challenge because in chronic pain, oftentimes multiple locations of pain, like I see that's complex, it'll pull the primary diagnosis. And I may write one drug for one thing and another for something else, and it pulls the primary code. So if someone has like neuropathy and back pain or something, those are two different codes, but it'll pull the primary code. It actually takes a little bit to go in and undo that for the physician. And so, I don't think any of us do that. So I see how that could be a challenge. But I guess my point is more about data integrity, because one thing that we learned about ORS when it first launched, there was always a disclaimer on the bottom saying like, this report is not, there's no guarantee of accuracy on this report. And it wasn't accurate because a lot of pharmacies weren't uploading on ORS. A lot of hospital networks weren't. So for example, in Dayton, the VA wasn't doing it, and neither was the Air Force Base, which are two large hospitals in our area. So there's some big voids there, and it just took a long time. It actually took years to overcome that because physicians never trusted it. And so I think that that's important when this launches, is to make sure that we're as accurate as we possibly can be, because if we have a failure to launch issue, it could set us back. Yes, Dr. Schottenstein.
Thank you so much. I also have a recollection from a while ago when we were talking about, pharmacy reporting of these diagnoses, that the larger chains seemed to be more compliant. The smaller ones seemed not to so much.
I think that's another aspect of what the pharmacy board is working on with their data integrity, is not only reaching out to prescribers, but reaching out to pharmacies as well.
Okay.
So Brandy, that brings up another question I have based on what Dr. Schottenstein said. So when we put the diagnosis in as a physician and we send it electronically, does that pharmacist then have to key it in manually to some site? Or does it happen automatically, or do you know?
From what I believe is they key it in automatically. I can double check, but I believe it's keyed in automatically.
Yeah, I could see how, to Dr. Schottenstein's point, maybe some smaller pharmacies may not have the resources or ability. I don't know. That's a great point. Thank you for that.
Thanks.
Any other questions? Okay, I think it's probably appropriate.
For your EMR, Dr. Sohn, does it, for our Epic in the hospital, every single narcotic or scheduled drug prescription we write, it automatically, individually pops up for you?
You're muted, Sherry. Sorry.
I was saying that for our Epic and even our own EMR, we have NextGen in my office. For every single prescription that you write, if it's a scheduled drug, it automatically opens up the patient's diagnoses for you to pick. I can't just pick one and print out 10 prescriptions. Is yours different?
Yeah, so mine's different. I use something called eClinicalWorks, and they've outsourced their prescription thing it's a company, I think it's called SureScripts, to handle that that piece, the pharmacy piece. An interesting thing about SureScripts is that they've captured like 90% of the small EMR market space to handle that transaction. And when I key in a prescription and put it in and click to submit it, it will automatically pull in the first ICD-10 code that's listed on there as a primary diagnosis. And so I think there's variability in EMRs and some of that stuff to do it. To be honest, I was really happy when that feature came out because it was getting challenging. I used to have to free type in the diagnosis code under the comments section, and that actually was time consuming. So I preferred the automatic feature.
Okay, thank you.
Any other questions? Okay, I think now we can move on to the pharmacy board data integrity project update, which is a really key point of this whole puzzle, I think. Very key piece, I mean. Thank you.
Sure. Yeah, I agree. And I touched upon it a little bit already when I was answering your question, Dr. Soin, where we talked about how the pharmacy board is internally working with their vendor to identify different data points. And then from there, their outreach is going to be reaching out to various prescribers as well as various pharmacy systems, the smaller ones that you guys had mentioned that, could be having some issues with getting this information input correctly. They're also working on EMRs, identifying EMRs, how different EMRs pull information. So they're taking all of that into consideration as they're doing their data integrity process. So I think that's why we're seeing it take just a little bit longer. They've been meeting with us regularly, giving us program updates. So again, I'm hopeful that they can wrap up things on their end here over the next month, so that way we can get the tool rolled out. But again, we really feel like it's important to make sure that we have good data before we roll the tool out.
Do you have any, idea would be the correct word. Do you have any idea on the timeline and where they're actually at, in terms of what all they still need to do and when it might be ready?
So they had met with their vendor at the end of May, and they were working on starting outreach here this month. So I don't know how long it's going to take for them to collect the information and then make the updates. They know we're anxious to get our tool pushed out, and they've been really great in working with us and responding to all of our requests for assistance. So I'm hopeful that they're going to be able to move through it pretty quickly. I haven't been given a time frame, so it's still up in the air.
Yeah, and I want to make one point clear about what I just asked, and I don't mean to speak on behalf of all the board members here, so feel free to chime in. But I guess I'm not anxious necessarily to get this rolled out. I think the most important thing is that the data is accurate, because I just feel that if there's a problem with that, it's going to take, people aren't going to trust it for a long time. So I almost would prefer to make sure that they know for sure that to the best of their ability, it's all good, and then we can go. And I would hate to rush them into something where they're not really ready, because I want this to be a valuable tool that provides actionable intelligence for physicians and us and for everybody. So I just wanted to make that point clear.
Yeah, thank you. I completely agree.
And I think Dr. Schottenstein, you may have had a question.
Thanks very kindly. I think, if I may, there's another question too, which I would be glad for the pharmacy board to answer, which is what we're asking them to do feasible, right? In other words, we're proceeding in such a way as to say, this is a matter of time. If on some level they feel like it's not feasible, in other words, that it's not possible to get the degree of accuracy of data that we need, I would rather take a step back than go forward anyways. And to Dr. Sowen's point, have something out there that is counterproductive. So I would just be glad for their frank assessment in that regard.
Yeah, thank you. I would echo that as well. And so that would be a continuing discussion you would have with them. And I'm sure as things get updated, we'll be testing it and, making sure.
Dr. Choi, may I ask a question?
Of course, yes.
Brandy, how, this might be obvious to everybody on the meeting except me, how do they use this data? And do they have the same concerns that we have, right? So when we looked at this a couple of months ago, when we talked about the tool, the first thing that every doctor on the meeting saw was a data discrepancy on, and that data is out there now, right, on the tool that we currently have. So are they, I guess asked a different way, do they have the same concerns we have? And is it impacting their world in a way as well?
They do. They have the same concerns. They want to make sure the data is the most accurate as possible. So that's why they've been working to reach out and working with their internal vendor to make sure that they're getting the correct information internally in order to reach out externally to get the data, to get the feedback, to get the data the most accurate. So I'm not sure how it is affecting them from an internal perspective, but I know they do have the same concerns about data integrity.
Okay.
I just want to make another comment about how I, as a practitioner, look at this large data from ORs and stuff, and because there's been a lot of tools that have come out, and when I would look at granular data or total MED per patient and that kind of stuff, it was cool. It was nice to see that sort of lined out. I like that, but what was actually the most compelling to me and most persuasive is when the prescriber resource tool came out that had graphs that benchmarked you to your peers. That actually was really helpful for me to understand where I was at. And they listed like the number of prescribers in my specialty and how many patients they prescribed to and how many they wrote opioids and benzos. And there was just a bunch of data on there in graphical form. And I found that to be tremendously helpful. Not only that, it stimulated a lot of discussion amongst my colleagues. So when those reports first came out, I'm on multiple group text chains and stuff. I mean, people were really talking about that. And I'm just mentioning that, for utility of a tool as a practitioner, as a long-term goal, those types of things were at least impactful for me. And I know other practitioners, and it actually, when you realize you were an outlier compared to your peers, it was persuasive for you to adjust your behavior. Just a thought.
And that is something that we would like to include as a resource underneath the tool. The pharmacy board is working on updating their like brochure, their informational packet that talks about that tool specifically. And so we would like to incorporate that information underneath our tool as a way to direct somebody who may be looking at our tool and saying, hey, use the information that you're finding from our tool in conjunction with this self-reporting tool that can compare you to your peers as well.
Yes, Dr. Feibel.
Yeah, I would agree with Dr. Soin. Good point. That is by far the most important thing I think we can do, is because the practitioner that wants to be compliant and that wants to do the right thing, they're going to change their behavior. And the one that doesn't is not going to change their behavior. So I think that tool is by far the most important and should not even be a click. It should be somehow automatically on the report. So you don't have to click through it to find it. It should be one of the first things on that report if we have any say so in how this report is reported out, so to speak.
Great feedback. Dr. Schottenstein?
Thank you so much. I had mentioned in the past that I would also be grateful for a prescriber report, right? I don't write opioids, but do write stimulants and, some benzodiazepines. And lo and behold, I got a prescriber report. So just wanted to say thanks to whoever put that out. I really appreciated it very much.
By the way, when you got that, you don't have to say anything you're uncomfortable with, but wasn't it enlightening? I mean, it compares you to your peers and like how many you write and the graphs. I found that to be really a cool tool, because for those of us who practice, in a small group or even private practice, you kind of lose that sense of, okay, where am I compared to everyone else? And that was helpful.
Absolutely. I mean, I'm in solo private practice, so it's super helpful for me. And I did very much appreciate the feedback I got on it, and if it's not trouble, I have another thought as to what could be included on this report, which is whether or not a practitioner misses any ORS checks, right? So by and large, a practitioner is trying his or her best to, check ORs on every patient who is supposed to have that. It would be nice to be able to have that data presented to us as well. In other words, here are the names of the patients who should have had an ORS check-in, did not, right? Just my 2 cents that could be additionally helpful material, because if it sort of sneaks past a practitioner, I think the practitioner would want to know that, if it's feasible.
Yeah, and I know you have a question, Dr. Reddy, and Brandy, I do have a comment on that. So as you hear some of these ideas, it'd be a great idea to talk to the pharmacy board, because if they're already talking to the vendor, maybe it's an easy thing to integrate. And if not, if it is going to be challenging, perhaps we can roll this out in tranches or stages. So it's not, so at least we can get some tool out as long as the data is accurate.
Absolutely. Thank you.
And Dr. Reddy, I know you had a question as well.
Yeah, so when this ORS report became, we have to check it. When it became compulsory, following that, we used to get emails from the pharmacy board that you have not checked in on so many number of patients per month. And later on, it has become less and less, because in our office, we made it certain that before any prescription goes, the first thing we have to do is ORS check. And just as Dr. Johnson was saying, we work with Epic, and Epic has a small click where it tells you who is writing the prescriptions and how long. So I feel that pharmacy board is doing a good job in helping us as individual practitioners, whether we are on the same track what they want or not. And I'm not certain, I didn't get any email recently, at least for the last 2 years. So maybe I'm doing 100% good, I don't know. But I would like to ask Dr. Soin if he gets any such emails, if he misses.
Yeah, I can tell you this, if you haven't gotten an email in 2 years, you're doing a really good job, without disclosing anything that I'm doing in my practice. And I haven't gotten one either, to be honest, but I do know practitioners who have, quite frankly. And so they're still sending out those, they are automatically generated, I believe, if you're missing those. So, I think you're doing a good job. And, I think the data shows that a lot of our practitioners are doing a great job. So a testament to our physicians who have done a great job with that. But one problem I always had with ORS, getting back to data, is that just because you check, you could still be non-compliant or an overprescriber and check ORS at the same time. That's why I really like the benchmarking data, especially if you're not aware that you're way overboard when you prescribe. So just checking your ORS alone, while that's a great one thing to do, I think it's also helpful to know whether or not, you're an outlier, so that's important.
So there is also a reminder from the pharmacy board that they want to check on why we are writing more than a specified MED. For example, for our state, it is 90. So two things need to go into our dictations. Why I am writing such a higher dose of this medication to a particular patient, which is also a very nice way of expressing ourselves as a physician if we write a little bit more.
Yeah, correct. So if you are a physician and you write for acute pain, and you actually go above 30 MED for a 7-day fill, a lot of times you will get a call from the pharmacy themselves, asking why or questioning it. But doctors that are doing chronic pain management and in a community for a long time, I think a lot of pharmacists might have awareness that it's more of a chronic pain issue. You may not get a lot of those calls. Dr. Feibel?
Yeah, regarding that, not to bog down because we're kind of off topic, but brought it up. We do get calls from the pharmacy for acute pain, and actually some pharmacists have refused to fill post-operative pain prescriptions for patients of ours. For instance, for a posterior tibial tendonitis diagnosis where they've had a major surgery where we've cut the heel bone, shifted it over, and and transferred a tendon, they say, well, this is not worthy of you giving this type of pain medicine for they have a tendonitis. And even on talking to those pharmacists, they often won't fill it. So the patient has to go to another pharmacy to get it filled in the postoperative period. And it's really a problem. So I've talked to the pharmacy board executive director about this, and I would love it if the pharmacy would regulate their physicians to not be policing us. And if they have a problem, fill the prescription and then report it to the medical board if they're concerned in some way, as opposed to withholding treatment from the patient. It's wholly inappropriate, and we should be able to. A pharmacist should not be able to withhold treatment from a patient after. I don't mind getting a phone call, but after the explanation, if they have a problem with it, they should deal with it through the medical board reporting system rather than withholding treatment from a patient. So, just a comment.
Thank you. Also, didn't mean to get off topic, but since we're discussing it, it's actually helpful that you brought this up to me, Dr. Feibel, and I'd love to talk to you more about that, later. But one of the things when we were doing this acute pain rule, I had an impression that orthopedic surgery was going to be problematic for this 30 MED, particularly for the surgery that you mentioned, but also, things that require extensive instrumentation of the bone, just because bones have a lot of nerve innervation around it and the tissue around it does. And so we tried to create exceptions for the 30 MED rule. We also thought that burns would be another one. We thought that crushing injuries, and actually, I believe we even memorialized major orthopedic surgery as being excluded from that 30 MED rule. So I think that that's helpful for me to go back to them to say, by the way, we just need to make sure that those particular instances, the patients should be allowed to get more than 30 MED for 7 days. I do appreciate that the pharmacists are policing it and that kind of stuff, but that seems like not consistent with what we were trying to do.
Dr. Stoyan, just to let you know, major orthopedic surgery is an indication where the MED could be increased.
You said it is or is not?
It is.
Yes,
Yeah.
I actually specifically remember a discussion about that because I felt that, it was going to be difficult for the patients,
Yeah, it's traumatic crushing of tissue, amputation, severe burns, and major orthopedic surgery.
And I brought that to the pharmacist's attention when this happened. This happens all over the orthopedic world on a regular basis. There were a couple, I don't want to mention their names because I don't remember which outlets, but there were a couple pharmacy outlets that were not allowing their pharmacists to prescribe over 30 MED except for chronic pain or cancer patients. And so the pharmacist would not comply. So the patient had to go post-operatively, they're driving home, they have to go to a different pharmacy. It's really bad for the patient. And so I asked the pharmacy board if they would, send out a communication to the pharmacist saying that this was inappropriate. I know I filed some complaints to the pharmacy board on this and never really got any resolution on it, but it really is a problem, and we should make sure that pharmacists know that it's not their job to police the physician, but rather if they have a problem, report it to the medical board, but comply with the request for the patient's benefit.
Yes, thank you for that comment. And actually, it was very enlightening to hear that because it's not something I treat, so I wasn't aware that was an issue. Dr. Reddy?
So I work with quite a few neurosurgeons who do quite extensive spinal fusion surgery. And about 2 or 3 years ago, this used to be a big issue, the pharmacy not filling the prescriptions. So the neurosurgeons then started checking the orth report and making sure that, this is a long segment spinal fusion. So they are now prescribing up to 3 months. And I don't get any of those patients to be seen post-operatively for about 3 months. I think if the note clearly says this was an extensive surgery, it suffices to satisfy the state pharmacy board.
Yeah, no, and I agree with you on that. I think documentation is important for all doctors. But to Dr. Feibel's point, it's a challenge, right? If the pharmacy calls back and delays a script, and then you have someone that's really suffering in pain, because we all know this, but immediately after tissue injury, so immediately after the surgery, especially the first 72 hours with all the inflammation that's going around on the soft tissue, I mean, that pain can be tremendous. And, to delay that is challenging. The minutes feel like hours for patients when they're waiting to get out of pain. So I think we can do a better job. So that's a topic we can, sort of discuss internally amongst our board staff and reach out to the pharmacy board. But I think since that's, in the rule and we seem to be seeing it in the community as being an issue, it might be worthy of a discussion with them. So thank you, Dr. Feibel, for bringing that up. Any other questions? Okay, seeing none, it was a great discussion, actually. Thank you, everyone, for that. And so I think we have gone through our agenda items for today. So if there's a motion to adjourn in a second, we'll take that.
I move to adjourn.
Second.
And Dr. Johnson, second. All in favor, say aye. Aye. All right. Thank you. And we'll see you at the meeting, board meeting.
This conference is no longer being recorded.
Thank you, everyone.